and then Jody, you're okay, and I'll keep your time.
Okay, thanks. So thank you everybody again for having me, and I'm honored to be here with both Pat and Marilyn. Um, and thank you all for being a part of CARA. Since our inception, the Gray Panthers of San Francisco have been a part of CARA and helping us get started. And so you're definitely part of the family here. Um, so there's probably no one more informed about the status and the challenges facing nursing homes than Pat. So I'm not going to go into a lot of detail because I actually think she can be much more informative. I will say that, for years, as we've tried to look at every issue from, in large part with leadership from Canner, from, staffing standards and infection controls and transparency and accountability by nursing homes. It's a continual struggle, and we're dealing with an industry that is completely unaccountable and non-transparent. And when we entered this pandemic, all of the problems we already knew existed only got amplified. And I don't really, one of the things that happened that to this day, I don't really understand it, except Pat was alluding to some of this before we actually got started. So many of the people who are in nursing homes are paid for through Medi-Cal dollars. And even if they started paying privately, you go through your money pretty fast and become Medi-Cal eligible. And the reimbursement rate for Medi-Cal is lower than the reimbursement rate for Medicare. So there's so many really obscene incentives in the way Medi-Cal, our nursing homes are structured and administered and financed, that when we hit the pandemic and people were being released from acute care settings into nursing homes, the worst place you could possibly transfer somebody, because historically nursing homes have been understaffed, very limited, if any, infection control, in a congregate setting, and then you bring somebody who is struggling to recover from a communicable disease to a place that can't do a very good job on a good day and dealing with those kinds of diseases, it was beyond the pale. And how the administration came up with that, certainly the nursing homes were anxious to accept folks, because when someone comes from an acute care setting, as Pat was saying earlier, they come with Medicare reimbursement rates, which are higher. And so from the very beginning, in the context of the pandemic, there has been an outcry against both the nursing homes being a place for COVID rehabilitation, while they can't seem to keep their residents or their workers properly protected. At the same time, we're trying to deal with ensuring that the pandemic doesn't spread, and it became horrendous. And so there was a huge outcry against this practice, and it opened the door for a lot of the same advocates and new folks to look inside and really understand some of the structural problems with nursing homes in general, many of which Canner and those of us who are trying to be supportive of Canner's leadership have attempted to address kind of piece by piece. And I think the rabbit came out of the hat, and many people saw those inadequacies. And so when we talk about later in our conversation about what happens next, I think there is a much larger constituency interested in focusing on trying to figure out how we improve and repair this very broken industry in California. And the truth of the matter is that part of the reason why so many people wind up there, many whom don't ever want to be in a nursing home or congregate situation, is because we don't put enough effort, resources, training, workforce, all of that into an expanded long-term services and support system that allows people to stay home in their communities with the support they need, and in many cases, minimal home care support and associated services like meals possibly, or transportation services, but with a combination of all of those things could live very healthily, happily, and probably with much better outcomes in terms of their health where they want to be at home. But our system is so skewed and geared towards serving certain populations and not others. So if you are low income enough, you have access to services and supports that people who are upper poor and middle income don't have access to, because these services are designed as Medicaid waiver programs, and they're income based. And so a lot of people wind up being forced into an environment that isn't the right place for them for a whole host of reasons, because of resources and not being ineligibility for the services. And that is, so moving to the master plan for aging, one of the main foci, I think that's the word, of that group, and the first set of recommendations that were presented to the administration and the governor were around long-term supports and services. And we, along with many of you and others who are part of our family, advocated very strongly for the creation of a universal LTSS, long-term supports and services benefit that would be available to everyone, so that we would actually have the choice of aging in the place where we want to age with enough support, whether it be from a paid caregiver or a family member, but with enough support of those family members so that they can provide support for us, but also have respite and support they need, so that their choice is not quitting their job to care for someone because they can't afford to pay privately for those services. So looking at how we really create an environment where we can age in our place of choice that's appropriate for our situation. And poll after poll shows that most people, if they're able to, would prefer to stay at home in their community with supports, so that they don't wind up in a congregate setting. There are some people who require the kind of 24-hour care that a congregate setting provides, but the reality is many people can do without. The problem is they can't afford it. And so we've really been looking at how you create a benefit that everyone could have access to. Really, Medicare should be paying for this benefit, but as we know, Medicare only pays for the first 100 days of rehab care, and even in some cases home care with assistance, but it's upon discharge from the hospital. What does that one mean?
1 minute.
Oh, okay. All right. So I think that what I found very encouraging through the Master Plan for Aging was a consensual position from all of the participants in the stakeholders group and the communities from which we all come to move towards a reconfigured LTSS program
Wonderful.
that
Try to
that
forward
can
her the
benefit.
invitation, although she's gone to the website already, so she's good.
We've
Could
got
you, people who are talking, if they're, turn off your mic, except the speaker. Okay, Jody, go ahead.
So I feel very optimistic about sort of a community approach towards both supporting an LTSS benefit for all, as well as a commitment from a larger network of folks to really start honing in on the problems with the long-term problems with nursing homes, and how collectively we might be able to work together to demand transparency, demand accountability, demand better care, better staffing, infection controls, all the things that have become so apparent in this pandemic, but were here way before. And so that is encouraging that there is growing knowledge of it. We've kind of taken the blindfolds off. The pandemic forced us to do that in some ways that we hadn't before, and I think we're ready to start moving forward.
Okay, thanks, Jody. Next, we're going to hear from Pat McGinnis of Canner. Patricia McGinnis is the co-founder and executive director of California Advocates for Nursing Home Reform, a statewide consumer advocacy organization formed in 1983. A former teacher, Ms. McGinnis received her Juris Doctor from Golden Gate University of Law in 1977. She's been involved with long-term care reform issues for over 35 years and has written and lectured extensively on issues such as long-term care, elder abuse, residents' rights, home and community-based alternatives, and the use of restraints in nursing homes. Ms. McGinnis is also an adjunct professor in San Francisco State University's graduate gerontology program. Thank you, Pat. And here's your 10 minutes to talk about the problems.
Yeah, 10 minutes, huh?
Yeah, well,
we could go on forever.
And
no, I appreciate the opportunity. Actually, years ago when I was starting Canner, it was Bay Area Advocates for Nursing Home Reform. I was on the board of the Gray Panthers in San Francisco, and I had my first office in Berkeley, right across from the Berkeley Gray Panthers. And between those two groups, they really helped start this organization. So I thank you. I'll follow up with Jody's absolutely right. This kind of pulled the blanket, the cover off of the horrible problems that we have in nursing homes. We've known it for years, but now everybody can see it. It just took the Band-Aid off, and you take a look at that. For those of you who don't know California Advocates for Nursing Home Reform, we have a website, www.canner.org. We have fact sheets on every area of long-term care, on home and community-based services, residential care, nursing homes, your rights, arbitration agreements, almost everything you need to know about long-term care you can find out from our office, and we have an 800 number as well. But we do legislation, we do litigation, we have the only statewide state bar certified lawyer referral service in the state that specializes in elder financial abuse and elder abuse in institutions. The state of nursing homes in California, well, I'll tell you, I was just looking up statistics this morning. This is September, and this was as of September 20th. There have been 4,379 COVID-related deaths in nursing homes in California, with 25,500 something infections. 40% of the COVID-related deaths in this country are in nursing homes. So that tells you something like that right there, but it's not surprising. I mean, we looked at California's 1,200 plus nursing homes, and they are the perfect incubator because of the same kinds of things that Jody was mentioned, for something like the virus. Before that, we had sepsis, we had MRSA, we had C. diff, and they weren't able to even deal with those kinds of infections. 50% of the nursing homes in California had deficiencies in infection prevention and control. Things like not wearing gloves. Well, the Department of Public Health found those to be minor infractions. Today, that could kill you. So it's not surprising at all that these kinds of things happen. Years of understaffing, poor infection control, toothless enforcement by the Department of Public Health have led to dangerous and careless practices and the tolerance of poor care. And that's what we see in Sacramento. They tolerate this. We tell them time after time of the horrible abuse and neglect that goes on, and it seems like it just kind of flies over their head. The nursing home industry has an enormous grip, and I'm not talking just about Republican legislators, on all of them, including our governor. They have an enormous grip on the people in Sacramento, and it's very unfortunate. A lot of that has to do with the kind of donations they give to these, our so-called elected representatives. The days of having people like Leo McCarthy, Art Agnos, Diane Watson, they're gone. Sheila Kuehl, Those are gone. We don't have heroes in Sacramento anymore. We have people who are more than willing to do the bidding of the nursing home industry. So when the virus came down, nursing homes were completely unprepared to protect their residents or their staff for that matter. They were incapable of providing preventive care because they never had to do it before. 65% of the people in nursing homes in California have all or part of their costs paid for by the Medi-Cal program. They didn't start out that way. If you start out private pay, you could go through $100,000 within 3 months in a nursing home very easily. So many people who start out private pay or who start off with Medicare end up on the Medi-Cal program in California. So we have massive Medi-Cal discrimination. Try to find a facility to accept your mother who is on Medi-Cal. If she goes into the acute care hospital and then she comes out after a 3-day stay and she goes into a nursing home, she'd be able to find a place. But if you called a nursing home and said, well, my mother's eligible for Medi-Cal, you're not going to find a place. It's as simple as that, even though the majority of their money comes from the Medi-Cal program at this point. So anyway, I'm sorry, staffing. We've always had low staffing in California. 70% of the hands-on care is provided by underpaid, undertrained, and overworked nurses' aides. There's no question about that. So when the $15 billion came down to the nursing homes and the additional $5-point-something billion came down from our tax money to the nursing home, none of that went to nurses' aides. They didn't get hazard pay. They were told, come to work or you're gonna get fired. It's as simple as that. And one of the things that we're calling for is hazard pay for nurses' aides and increased wages. There's no question about that. About 50% of the nursing homes in California filed for staffing waivers. What does that mean? It means we increased our staffing requirements to 3.5 nursing hours per patient day, which is really nothing. I mean, it's not even close to the safe staffing standards that even CMS says is 4.1. Nevertheless, nursing homes went nuts because when they take over a facility, the very first thing they do is cut the staff because that's their highest cost, the personnel cost. And so nurses' aides always come out in the bottom. So they were given billions of dollars for COVID care, but they didn't pass any of it on to the staff. In March, what happened, the very first thing that CMS and the state of California did, they closed all the facilities to visitors. That meant no ombudsman, no family members, none of the caregivers who come in every day and make sure that their person is turned, make sure that their mother and father are eating, make sure that their kids their wounds are being taken care of. All those people were banned, including long-term care ombudsman. But the irony was that also the Department of Public Health evaluators also didn't go in. So people in nursing homes were completely at the mercy of understaffed, poorly trained nursing staff. It's no wonder then last week a study came out in the New York Times that there's a 20% increase in dementia deaths in this country in nursing homes. No wonder. And I guess when we look at things, we have 2 recent studies. They show that the factors, that there's a very close correlation between the lack of RNs, and we have very few in nursing homes in California, and outbreaks and deaths in nursing homes. We have few RNs at all in nursing homes as part of the staff, and most are certainly not 8 hours a day as required by law. Other factors, history of health deficiencies. We know for sure because we've talked to probably 500 media people since this began in March and looking up the statistics and deficiencies. The poorest facilities, the ones with the highest numbers of deficiencies, the worst records of care, had the highest number of COVID and had the infections and the highest number of deaths. There's a high, and you can also look at the history of health deficiencies, a concentration of Medi-Cal residents. The higher number of Medi-Cal residents, the more likely you are to have an outbreak of infections because they're going to have lower staff. The concentration of ethnic and minority, racial minorities, that also is in communities, and we see that all the time in places like Los Angeles, particularly, where you have a high number of infections, very, very few staff, and very poor care. So these just heightened the outbreaks and the deaths. And the other big factor is the poor enforcement. We've been going through this for years. 1 minute. Okay. We have a history of weak enforcement. Very, very few fines, most with civil monetary penalties. And we have a civil monetary penalty fund. A nursing home can get fined for a AA citation if what they did actually killed somebody, if their violation. They can get up to $100,000. They can get up to $10,000 for an A, or a B citation for $5,000. Most of the money isn't collected in the first place. And secondly, you know where most of the money goes? It goes into a civil monetary penalty fund, and they give grants to the CAF, the California Association of Health Facilities, which is the lobbying arm of the nursing home industry. So we've got a sick system, and we've got to change it. And I believe, like Jody, that the temperature is things are going to change. Any civil society would think that cramming sick elders and persons with disabilities into dirty, smelly 2- and 3-room places, and that we're going to provide care and underpay staff. This is just a horrible, horrible, uncivil way to care for our elders and for persons with disabilities. And we're going to change that, no question.
Thank you, Pat. That was a powerful statement. Our next speaker is Marilyn Albert. She's been a nurse and healthcare union activist for 45 years. She was shop steward and organizer for local 1199 SEIU in New York City, an organizer for National Nurses United and for the National Union of Healthcare Workers until she retired last year. She's been active around single payers since the 1970s and lives in Richmond. Marilyn, go ahead. You have 10
Thank
minutes.
you. I'm going to repeat some of the themes from Jody and Pat. It would not surprise you. We've been taught some brutal lessons about the system of elder care in our country during this pandemic. It's brought long-standing problems into the open. As of September 18th, a few days ago, excuse me, 76,270 residents and workers in long-term care facilities have died of COVID. This is considered an undercount because a lot of facilities fail to report to the government. In fact, in today's New York Times, it was reported that in New Orleans, 1 in 10 deaths in nursing homes were not reported to state government. Excuse me. Just today, 2 hours ago, I saw a study which has come out about assisted living facilities, and that there's a huge disparity in the death rates from COVID-19 in assisted living compared to the statewide general death rate, and especially in those facilities which have a higher number of minority residents and which are under-resourced. Why have 40% of COVID deaths been in nursing homes? The answers point us toward big structural change, which we should fight for. People like me, I just turned 70 and I have no children. So people like me ask ourselves, what will our future be like? Should I ever move into a congregate setting? How can congregate living be made humane, safe, and enjoyable? Is it possible to end the need for these types of facilities? Worker conditions, poor pay, lack of sick time, and other benefits have been pointed to as a cause of the crisis in the nursing homes, as Pat just talked about. The turnover rate in these facilities is extremely high. Many of the workers have more than one job, which did contribute to the spread of the virus because people were going from job to job, even 3 jobs some people have. Understaffing is severe, and it has been since long-term care has been an industry. Being a nursing assistant in elder care is one of the hardest jobs in this country, with the caveat that there are some good nursing homes. They are a minority, I think. Nursing assistants in these facilities often care for, in California anyway, 15 to 20 patients on their shift. That's the experience of the union, NUHW union, that I retired from. They feed and they clean the patients and have to turn them from side to side, raise them into a sitting position, transfer them into a chair, dress them and take them to the bathroom, and sometimes struggle to pick them up when they have fallen, all of this without the help of another worker. Most homes are not staffed for 2 workers to work together. These workers have a high rate of shoulder and back injuries. The homes won't buy enough, as Pat made the point, the homes won't buy enough supplies, and then workers develop unsanitary habits because they're denied proper supplies. This obviously became a huge crisis when the pandemic hit. Most regulations require only 1 registered nurse on duty on a shift in a nursing home. Therefore, residents do not get assessed enough by a qualified nurse. My own experience working in emergency rooms was that you would get a call as an ER nurse, you would get a call from a home saying that a patient was being sent to the hospital, let's say because the patient had a temperature of 101. But when the patient arrived in the ER, they were in critical condition. And this was a very common experience that I used to have. These conditions were the crisis before the pandemic. Then the lack of protective equipment was added, also the mixing of infected and non-infected patients together, and dozens of other failures of the nursing home administrations and the state and federal governments. All of this has led to the 76,000 deaths. One exception to the pandemic, which was described in the news outlet Politico recently, in California, seems to have been the 8 homes which are run by the California Veterans Affairs Department. An average nursing home patient in California is 31 times more likely to die from COVID-19 than a resident of one of the CalVet homes. With good leadership, these homes were kept fully staffed and supplied with protective equipment. An investigation by Politico revealed that the CalVet leaders started planning as soon as the news of a novel virus in China was visible on the CDC website around New Year's Eve. And now that CDC website has become a major controversy in this country. Shortly after the January 21st case in Seattle, which was considered the first case in the United States, the CalVet administration was having daily Zoom calls to plan, and they started retraining their staff on infection control. 10 days before Trump declared a national emergency, every CalVet home had a detailed protocol in the event of a suspected COVID case. So I'm describing this to say that the catastrophe in elder care facilities could have been avoided. If we concede that in an ideal world, we will still need some level of congregate care, 3 solutions I will discuss could transform these facilities if we can build the political will to enact them. And so those 3 elements I'll talk about later. Thank you.
Okay, Marilyn, thank you very much. So what we're going to do is we're going to go into a second round that'll be talking more about the vision and solutions. How can we fix this? And then we'll do Q&A at the end of the second round. We're going to probably take a 5-minute break between the end of the second round and the beginning of Q&A. If you have questions, you could put them in the chat, and we'll go through the chat, but you'll also have the ability to raise your hand and ask them directly. Okay, so now we'll begin the second round with Jody Reed. Jody, talking about what you've learned from your experience in dealing with the governor in budget negotiations, through your testimony at the Master Plan for Aging, and what other insights you've come to how we can fix this problem. In 10 minutes.
So the Master Plan for Aging, which is a 10-year blueprint to try and come up with changes in both leadership and structure and kind of moving away from the silos that we now have in government to a more coordinated approach, looking through the eyes of the person, through person-centered care. The language in the master plan recommendations and from the administration is often stellar. But as we all know, from years of working on these issues, moving from a document that's 1,000 pages into a real commitment from the administration to act and to implement some of these recommendations is a whole nother story. And if we use the budget process that happened this year as a window into how elected officials and administration bureaucrats act, you know, yes, we have a huge budget crisis at the state level. We're in a recession. COVID has made it abundantly clear. And we're dealing with the high percentage of deaths and infection in very vulnerable populations, you know, people who are older, people with disabilities, people from racial minority groups being the having the worst infection rates and the most deaths, prisoners in congregate facilities. That in the midst of all of this, where all these deaths and infections were happening in these congregate facilities, when we're in the budget crisis, what programs were the first to get proposed for slashing? The very programs that were helping keep people out of those facilities where the deaths were occurring. So as much as people talk about the need to support services at home, to put more resources into the programs that help keep people healthy, the exact opposite happened in the first round of budget proposals. And it took all of our advocacy and kicking the can down the road, if you will, by the governor to like shake their heads and say, this is a big mistake, because we're just going to compound the problem that we're already dealing with. And this is not the time to be cutting the very programs that can help people, or at least prevent them from winding up in a situation where the deaths are occurring. The same thing is true now with the Master Plan for Aging. For those of you who've been following the process, the last public meeting of the stakeholder group was last week. And we have until the end of this week to add any suggested changes from the public and from participants. And then it goes to the administration and the governor, and they have until December to decide what to do with those recommendations and actually present the administration's master plan on aging. So we were advisory. We weren't the final word. And so the work is really just starting, because we got some great recommendations in there about nursing homes, about long-term supports and services, about affordable housing, about healthcare, but they are meaningless unless we are committed to work together to make sure that those recommendations become the administration's recommendations, number one, and then two, that we begin the process of implementing them. And that's going to take as much work, if not more, from all of us to make those recommendations that are well-founded, that have consensual support by a very diverse group of stakeholders and public folks. But the public needs to be pushing our elected officials. And as Pat mentioned, we don't have a lot of champions in the legislature right now, because many of them are beholden to the nursing home industry in the case of this topic. But, you know, in the pharmaceutical industry, the insurance industry, the real estate developers, I mean, we have a bought and paid for legislature for the most part. And so the only way we're going to make the recommendations in the master plan and beyond a reality is if we force our elected officials to do it. So it's now on us to do the organizing and the educating to make sure that we hold them accountable to the recommendations that, like I said, a very diverse group of folks have supported and bought into. And that if this is really a goal, then resources should be available to help implement these goals. And furthermore, the administration has a nasty habit of always talking about how much things cost. And so that's the roadblock. We can't do this because we just don't have the money. And you all know that we're in a recession right now, and the pandemic has really drained every resource from our local and state coffers. And so we'd love to do this, but we can't do it right now because we don't have the money. And they never talk about how good programs and good policy and good practice can save money. That if we took care of people from the very beginning through their lifespan and had health care for everyone, access to care in every community, that we could prevent some of the situations that wind people up in having to make difficult choices about whether they can care for themselves at home with some help or wind up in an institution. Institutional care costs way more money than home-based care. That doesn't mean we're not going to ever need it, but we can prevent a lot of people from spending down every last penny that they have and wind up in a nursing home with Medi-Cal and taxpayer dollars paying for it. So I think part of our charge is making it very clear what we can save, not just in money and resources at the state level, but in human lives. And if we're a state about values and valuing people and valuing our diversity and valuing our age and valuing our ability or our disability, then our money should be about following those values and not about, you know, the bottom line. And especially when following those values could actually save us money in the long run. So I think we have a lot of work to do, but I'm very optimistic that a much more diverse and engaged network of groups and service providers are ready to continue working together. And we need to figure out how to bring us together on the issues where we agree, and pushing the administration to actually enact some of the very strong recommendations that have come out of the nursing home coalitions that have gotten the attention of the Department of the Secretary Galley and the Department of Health and Human Services, the master plan recommendations, the Alzheimer's recommendations. There's recommendations galore. The issue is how we move forward in a united way to really prioritize and organize.
Thank you, Jody. I want to make sure that you get a chance to talk a little bit about Prop 15. You want to do it now or later?
I can say something really quickly.
Okay.
I mean, certainly, you know, the resources are needed. We're in a very difficult situation. And now we have an opportunity to do what we should be doing more of. So Prop 15 is an opportunity to bring $12 billion a year into our local schools and communities to help support the kinds of services that we're talking about here, whether it be emergency responders or health centers or public transportation or housing. It will be up to each community by making corporations pay their fair share. And this model that's going to go, that will create local dollars to help us in our own communities should be modeled at the state level. So at the end of this legislative session, there were a couple of pieces of legislation to create a wealth tax. So that's on total wealth, as well as a proposal to raise the income tax on people who make over $1 million a year, and it went up per million that you had. Neither of which made it through the legislature because you need a 2/3 vote to pass a new tax in the legislature, and Democrats and Republicans voted against against those proposals. So we have to keep pushing on that because the wealthy got all these tax breaks from the Trump administration and from our existing tax laws and have not paid their fair share. And we need to keep pushing for progressive taxes where the wealthy who have benefited from all of these tax breaks actually pay their fair share. And the first chance to do that is by passing Prop 15 and on the issue of property taxes, make corporations pay their fair share and get reassessed regularly, like every other state in the country already does. We are the only place that does not regularly reassess commercial property. And because of that, for the last 40 years, we've lost a tremendous amount of money, over $150 billion is estimated, to our schools and to our local community services. And right now we need that money just to keep things afloat as we look for other progressive revenues. So I hope you'll all vote yes on Prop 15 when you get your ballots.
Thanks, Jody. Would you put any resources in the chat about how people can help pass Prop 15? If there's any like website to look at or any phone banks or whatever activities that people can engage in to help Prop 15. And thank you for your forward-looking remarks in the second round. We're now going to our second speaker in the second round, and that's Pat McGinnis from Canner. For people who arrived late, Pat McGinnis is the executive director of Canner, and they do a lot of the legal work representing and helping people in long-term care. And they have they're a great resource. Look at their website. I'm sure Pat will put the website in the chat. So Pat.
Oh, I will do that. Thank you for reminding me.
Yeah, what do you see, what can be done about this from Canner's point of view with all the problems we've heard about today? And there's, you know, what is your, what do you recommend that can be done? What can the legislature do? What can lawsuits do? What can we do?
Well, we're working on some lawsuits right now, and certainly the legislature could do a lot of things if they had the will to do it. I'll tell you what, I'm not a pessimist, and because if I were, I wouldn't be doing this work. I would have quit a long time ago. However, as long as we have a for-profit nursing home industry, some of these problems will never go away. We need nonprofit. We need to take the profit out of nursing homes because they're answerable to their stockholders and not to their patients. And let's face it, about 40% of 70 to 80% of nursing homes in this country are owned by multi-million-dollar corporations, billion-dollar corporations. Many of those are real estate investment trusts. So they're buying the land. They don't give a damn about the residents. They're buying land. And what they do, they put that money together. They want more Medicare dollars. They got them. They want more Medi-Cal dollars. They're getting them. Every year, our governors give them more money, more money, more money. I have heard for 35 years, give us more money, we'll provide better care. I'm still waiting. Nevertheless, I am optimistic that we can see some changes. We put together a 10-point plan to reform California's nursing homes, but it really should be a 10-point plan to reform long-term care in California. And of course, our first is top priority to keep people out of nursing homes if they want. When we were on a conference call with the Los Angeles Department of Health back in April, one of the things, one of the spokespersons for the Department of Health said, you know what, I would really recommend that people take their relatives out of nursing homes and take them home. And of course, we got all kinds of calls. Where the hell am I supposed to put my mother? She's in a nursing home because she has all these different debilitating problems. I have 3 kids at home. I have a 2-bedroom apartment, or I have a 1-bedroom apartment. So we can tell people that, and we have these policy people in the departments of health saying all these nice things, take your relative home. Easy for you to say. There's no supports there for my mom. How am I going to care for my mother? When we look at home care, the home and community-based services, you know, there's difficult to access, there's limited slots, there's strict enforcement caps, There's wait lists, they're county specific. People will call and say, well, I want to get on this PACE program for my husband. I have to say, what zip code are you in? Because it really depends on what zip code. If you want the assisted living waiver program so that your mother can stay in the assisted living facility, you have to ask what county. And then even though you have counties that signed up for this program, you've got Santa Clara County, for example. They're eligible for the assisted living waiver program, but the providers don't sign up. Why? Because they don't think they're getting enough money to provide that level of care, which they're not. There's no question about it. Nevertheless, given all that, I think our top priority is to create models that people can choose to stay at home. Why in the name of God is this state willing to spend $60,000 to $70,000 a year to keep people in nursing homes, which is what they spend when people are on Medi-Cal? But they're not willing to spend $20,000 a year to help support them in a residential care facility, unless they're abjectly poor. And that's one of the biggest problems that we have, is the fact that we look at money and, oh, gee, we need money. We know home and community-based services saves money. We've seen financial analyses that show that it saves money. So we have got to do that. As far as I'm concerned, we look to Washington, we look to Oregon. If I need residential care in Washington or Oregon and I'm poor, I'm Medi-Cal eligible, I can get it paid for by the state. If I'm in Japan, I work very closely with a lot of the Department of Health people in Japan and went there several times to look at the kinds of facilities. They have a long-term care insurance system over there. South Korea, the folks from their Department of Health came to visit us about a year ago because they're setting up a long-term care system because they have a very high aging population. So until we take care of providing accessible and affordable home care, I'm trying to get my friend who makes $1,700 a month in San Francisco. She can't pay her rent and everything else. I'm trying to get her home care. You can't get it. You know what it costs? $40 an hour, $25 an hour. She can't afford that. And she's not eligible for the Medi-Cal program yet for the aged and disabled because we haven't implemented the 138% left. We always delay everything and it drives me crazy. Another issue is putting the home back in nursing homes. We've got to get rid of this idea that we can cram people into these 2, 3 bedroom, 4 bedrooms in some cases that we call the Medi-Cal ghetto in these facilities. We've got to get rid of that notion and just get rid of those facilities. We've got to set safe staffing standards and stick to them and not allow operators to operate if they can't provide enough staffing to care for the people that they're profiting from. We really have to we just change our whole model of care. We have to ensure that nursing homes are prepared for pandemics and emergencies. But what we've got now, this model that we've got now that we call nursing homes and care for elders is untenable. It's not working. We need to get rid of it. We need to just break it and start something new. And the only way we're going to do that is that we put more money into choices for people. $1,700 in San Francisco when you have nothing else is not enough to live on, but it's enough so that you are ineligible for all the assisted programs that you could possibly get in California. You have to be down to right now to less than $1,300 a month in order to be eligible for any of these programs, and that's absurd. Anyway, I'm done ranting. I'm sorry. I get really upset when I hear it, when I talk about these things. But I can tell you, until we change the legislature, until we get them, and I've noticed that over the years, I've been doing this for a hell of a long time, for well over 30 years. And I have watched legislators change. You know when they change? When their father has to go to a nursing home. I had one very, very right-wing Republican legislator come up to me when I was testifying on something and say, I apologize. And it turns out his father was in a nursing home down in Bakersfield, and it wasn't a very good facility either, even though this guy had been defending the industry for years. So I do have great hope, but I do think we need to look out of California. I think we need to look at models like Washington and Oregon, and look at places like Japan, and look at South Korea, and look at other countries and the way that they do things. And they know they don't have a lot of money either. You can save money by providing people with the kind of options that they need.
Thank you very much, Pat. And we're going to have one more speaker, then we're going to take a break. So it's your turn, Marilyn, to talk about what we can do, and you might incorporate, I think you might want to incorporate thoughts about what we can do better from the standpoint of workers and through single payer. But however you want to do it, you have 10 minutes.
That's what I'm going to do. But the first thing I'm going to do is repeat. I'm very happy to repeat one of Pat's main points, and that is that I don't think it's very hard to identify the central cause of this problem in the United States. But I don't think that change is inevitable, similarly to what Pat just said about legislators only wake up to this issue when it affects their own family. And you know, this problem of people not facing their elder years is a real problem. So I'm afraid this issue might become like the gun control issue, where the most horrific things happen and yet there isn't political change. So I think what may be considered a pie in the sky idea is actually now a societal imperative. And that is what Pat said. The profit in elder care has to be removed. And what's happening is the profit system is becoming greater and greater in the nursing home industry. In this country, 25% of hospitals are classified as for-profit. And these hospitals have been documented to provide lower quality care. They perform unnecessary procedures. They discharge patients too early. There's a host of deficiencies that for-profit hospitals are charged with, despite the fact that so-called not-for-profit hospitals are really make profits, but the segment that is just a raw profit-making sector is 25% of the hospitals in this country. But 70% of nursing homes are for profit. And so you compare that to 25% of hospitals. I suggest to you that this is the primary, but also reversible source of the problems that we are discussing.
Mhm.
The ability to maximize profit from elder care is constantly being refined in our present economic system. Private equity capital, which is a kind of hard to understand, but private equity capital is which raises its money from pension funds, institutional investors, and highly wealthy individuals who are kept secret of who they really are, and which the federal government policy highly favors. Private equity has in recent years been heavily involved in the consolidation of the hospital systems. And you see these chains of hospitals constantly being reorganized. That's because of private equity. They are now invading nursing homes. The places that are owned by private equity companies such as Goldman Sachs, Carlyle, and other of these capital funds with less well-known names employ fewer registered nurses and have paid more fines for regulation violation than the other so-called for-profit homes. Other privately owned homes, the kinds that are often owned by an individual or a family, frequently engage in what is called related party transactions. This is very common in the nursing home industry, where the owners of a nursing home chain will give business to another company that they own in healthcare. For example, the owner of a nursing home chain will refer a patient to a physical therapy company that is also owned by the same guy. The New York Times reported last week that homes are dumping their more expensive patients and discharging them on grounds of psychiatric problems. That the home is saying, well, this patient has a psychiatric problem, we can't take care of them, and they dump them. So there's always a way to maximize profits in this industry. We can expect now, because of the pandemic, that there will be a cry for nursing home reform following everything we've learned. Excuse me. Many will say that increased regulation is the answer. If strong regulations had existed and been enforced, we certainly would not be where we are. But we should fight for a solution which goes more to the root instead of an endless chasing of regulation violators. In my view, 3 solutions, when combined, could lay the basis for having safe and humane congregate facilities. They are, number 1, full unionization of healthcare workers. Number 2, severely reducing, if not ending, the role of private profit in healthcare and elder care. And number 3, enacting Medicare for all single-payer healthcare. You may not know it, but only 10% of healthcare workers in this country are unionized. And this is a big underlying cause of many of the problems that we have been talking about. But it's also the reason that these problems could be addressed effectively. The healthcare industry has engaged in sophisticated union busting, which has made it difficult for workers to organize. The high turnover rate in nursing homes also makes them particularly difficult to organize. There are new proposals coming from the progressive labor movement to fast-track unionization, and this should be a demand made by senior advocates in their own interest. If we call these workers our heroes, we have to treat them like our heroes and allow them to organize themselves if they want to. Secondly, it is simply criminal to allow what should be a public service for our elderly and disabled to be one of the most profitable components of an already highly exploitative broader health industry. This profiteering must not be acceptable anymore. We must build a movement which would be closely associated with the Medicare for All movement to end private profit in elder care. When I recently suggested this to a friend, she said, "You won't get young people to care about nursing homes." But I said, there are young people who care about nursing homes. They're the nursing home workers, who are overwhelmingly very young people. This movement could start by identifying the chains that are making the highest profits and having the worst conditions, such as my union, NUHW, has done against the largest chain in California, Brias. We must demand a public takeover of these chains, which brings me to solution number 3. It is the present health financing system that causes hospitals to send patients to nursing homes when they may not need to be placed in them, either in the short term or the long term. Enacting a single payer system could eliminate what incentivizes this practice. Long-term care is fully covered and explicitly described in HR 1384, the Medicare for All Act of 2019, which was introduced by Congresswoman Jayapal in the House of Representatives. It would be budgeted, as all health providers would be, through what's called global budgeting, it being elder care. So that patient advocates, family members, unions would have a voice in how facilities are budgeted. The progressive senior-focused organizations need to improve our messaging around Medicare for All and what it means for seniors. And Jody has been working on this with CARA, so that seniors have a clear understanding of what a single-payer system is and how it would benefit them, assuming that they're already on Medicare. Let's join the young people who have been leading the way in recent months toward a more united and stronger social justice movement and make big demands. We gray-haired folks still have a lot of time to do it. Thank you.
Thank you, Marilyn. That was great. Okay, now we're going to take a 5-minute break and then come back. In the meantime, if you have time, put your questions in the chat or raise your hand in the raise hand function, and we'll try to recognize you in order. And but please make your questions brief because we have 40 people on this in the Zoom today, so we need short questions and fairly concise answers as well. So 5-minute break going from 5:08 to 5:13. Okay, thank you.
Hey, Art,
Yeah.
I think putting the questions in the chat box is a very good idea, and at least so we get some idea, and people can also make comments, but it's hard to know.
Yeah, I'll
Yeah.
encourage that when we get back.
All right.
Okay, see you in 5.
Garbage. Pick up.
Hey, Michael, can you hear me? Hi, do you want to help me with looking through the chat for questions? Do you feel comfortable doing that? Would you rather not?
No, I can do that.
We have 35 things in the chat, but not all of them are questions. And you should not foreclose your own ability to ask a question. You can take, you can ask a question too. So
So do you want me to send questions to you via chat?
you could ask the questions if you could scan the questions and then see if you have any questions that are similar and then combine them, or you could. Do you feel comfortable doing that, or would you rather send them to me?
So I would be unmuted.
Yeah.
Okay.
Do you feel comfortable doing that? Like having pretty much control of the chat, and then I will keep my eyes open for people waving their hands or putting their hands in the raised hand function. I can watch for hands in the raised hand function and people waving their hands. I have more than one screen though. Let's see. So but I could do that. I could look for hand raised, and then we could alternate. Does that sound doable or not? Sure.
Art,
Yeah,
These are kick-ass people.
these are
Again,
great speakers. Yes.
a coup. I'm sorry I didn't quite have enough time we alerted our membership, but I didn't get to promote it uh, uh, with the short notice. Somehow I only
That's
just
okay.
saw it.
We'll have a
But what I
recording.
wanted, if I were to pick one, Pat McGinnis, do you think I could get her phone number or email?
You could,
Is she the canner person?
yes. Well,
Can you share her contact info?
no, it's public information. I mean, you can call Cantor. They have a good website. But
Okay, well, I'm
could-
trying to see or do you think you might have 5 minutes tomorrow to update us on the
Yeah.
nursing work we've all been doing?
Sure.
We're mostly
Yeah.
focused, yeah,
It's
Just if-
5:13. We're supposed to be back into the meeting. Michael,
that's all. Just want to flag you.
Michael, are you okay with what I've asked you to do, or you want to kick it to me for questions?
Sure.
Okay, well, so we'll alternate. Okay, is everybody back to their screen or their phone? So what we're gonna do is if you have a question, it'll go in the chat, or you can raise your hand physically or in the participant box. And Michael and I are gonna alternate questions based on the chat and and me seeing raised hands. So please make your question, as I said, please make your question brief. And if it's for a particular speaker, you can do that, or we can make it available for all three. But we only have 45 minutes. So be concise in your questions and answers. Okay, the first question is for Betsy. Go ahead, Betsy. Are you unmuted?
Yes, I am. I was going to look to what I said in the chat because I had several questions.
Well, just one question.
Yeah.
And make
Okay,
it
just
make it
one.
short.
Yeah, so I wondered if, so I have part of the Gray Panthers, California, I'm in the East Bay, and it's clear that I'm seeing similar patterns with our HUD housing through conversations with HUD tenants and people in our senior HUD housing, affordable housing here in Berkeley, that there's an industry, a for-profit industry that manipulates their contracts and has a lot of interest in the underlying real estate. Do you see that same thing? Do you know of co-investing nursing home real estate trusts that do nursing homes and affordable housing? If you've seen some connections, any of the speakers.
I can. I mean, Front Porch is a good example of that. They do so-called affordable housing. They're a nonprofit provider. They build continuing care retirement communities. Why they're called nonprofit is beyond me, because they do very, very little for the community benefit or for public benefits. They just affiliated with Covia. That's the towers in San Francisco. And how that's going to impact the care in that facility and the other Covia facilities. That used to be the Episcopal homes. And they turned into Covia. So now Front Porch and Covia are affiliating, and Front Porch is just property. I mean, and they pay a lobbyist in Sacramento a great deal of money, thousands and thousands and thousands of dollars, to try to defeat any CCRC proposal we come up with to improve residents' rights there. So that's one example. But they certainly do that in nursing homes. And like Marilyn said, Brios is a perfect example of related entities. We actually got the state of California to do a study about related entities based on Shlomo Rechnick's, because he and his brother own all these other health-related entities. If you look at the cost reports for nursing homes, for example, you will see that they will pay enormous amounts for leases and rents and things like that they pass through to the taxpayers as part of their Medicaid reimbursement. And yet they own the building, they own the property, another corporation. What happened, it used to be so easy. When I first started Banner, you had Beverly Enterprises, you had Hillhaven, you know who owned them, and you knew which ones they own. Now what they've done, so that once we got the elder abuse law passed so that you could actually sue, even if somebody died, it used to be if the person died, the case died with them. So we got the elder abuse law passed. So what they did is they set up all these little limited liability corporations so that if you can have one parent corporation and they would own 90 different nursing homes. And each one of those nursing homes is separately affiliated. The property may be owned by a real estate investment trust, and there's like 50 different corporations. In Shlomo's case, there's like 150 different corporations.
Right.
Ditto in senior housing. Thank you.
Yeah.
Okay, Michael, go ahead.
Yeah, Alan Cooper asks, is the proposal for state insurance reasonable, or will it become a boon for the owners and not help poor people because it's tied to past payroll tax payments?
Well, not the one that I'm talking about. If you look at Washington State is proposing something like that, I'm sure the COVID has put the blank on that for now. But if you look at the Japanese, if anybody, at first it was anybody who was 40 or over had to pay in to this tax plan, to the long-term care insurance benefit. But it wouldn't be, I'm not talking about boon for the owners. I'm talking about a long-term care insurance system. What was the Obama plan that was part of it that, you know, it wasn't mandatory and therefore it wouldn't go anywhere because there was no funding for it, but something like that, so that you could pay for long-term care services and supports. And that's what these other proposals, even South Korea, what they're proposing. And it's not based on your past tax. It's not based even on how much you pay.
But there, in addition to that, I mean, a larger solution, just to add to what Pat said, is that access to long-term care benefits, home and community-based benefits, should be a Medicare covered benefit. And the thought of creating yet another insurance vehicle where we have such bad experience with insurance already is very scary to me, where instead of, we should be looking, for me, and this is, you know, kind of Kara's position, these are a standard benefit, healthcare benefit for all Americans should be for our lifespan, from cradle to grave, or as Tom Mamiano always said, from sperm to worm. And that we should look at all of the benefits. And if we're all paying our share into a whole array of benefits, whether it's mental health or acupuncture, long-term care or dental care, the whole body, the whole person, all of our needs, and it's divided amongst everyone, and we're paying into that system in a progressive way, then we don't need all of these insurance models, which unfortunately I have very little faith in. And even if we could figure out a way to finance through payroll tax or whatever, a long-term care insurance benefit, I don't have a lot of hope for the insurance industry because they're bad players, just like the nursing home industry is. So really, I think our ultimate goal is that this should be a standard benefit as part of everything else you get when you have health care. And
I absolutely agree with you, Jody. And I don't think that this should have anything to do with the insurance industry. Oh, believe me.
Yeah,
Nothing.
no, I know. I'm not arguing with you. I'm just saying, I think that there are other ways to look at providing this benefit beyond just, you know, what could be a potentially more progressively financed insurance benefit. And I would steer away from the insurance benefit portion and look for making this just a standard benefit that everybody pays into.
Yeah, I agree.
Yeah.
Marilyn, did you want to answer?
I really agree with Jody. You know, there was a bit of a struggle in the Medicare for All movement over the last few years to include long-term care, and like everything else, the disabled activists forced the single payer movement in California and Bernie Sanders to some extent to make this a Medicare for All legislation, comprehensive, inclusive of long-term care and care for the disabled. But it took a bit of a struggle. So I think that that's what we have to fight for. And I also remember how happy I was 20 years ago when my hospital offered long-term care insurance. And I thought, oh, hooray, I can get long-term care insurance. And then I realized, then I woke up and smelled the coffee after about 3 years of paying premiums into long-term care, that it was a horror. So I really agree with what Jody has said.
Okay, I want to remind people that if you have a question, you can put it in the chat or you can raise your hand. And if you're on the phone and you want to ask a question, hit *9, and that will indicate, that'll put a signal to us that you want to ask a question and we can recognize you. Okay, the next question will be from Michael's list on the chat.
Yes, I wonder if you can describe how these different separate sources of money to cover different kinds of care has led to fragmented care and poor care.
Anybody in particular? Well, I mean, it's all Medi-Cal. You have to be eligible for Medi-Cal. So for example, you want to be eligible for the assisted living waiver program. You have to meet certain levels of income, very, very low. If you're on SSI, for example, or if you're on, you know, you're below a certain amount of money and you need to go into a residential care facility. So you have to need skilled nursing level of care. That's one thing. So you're assessed and and only certain counties is this benefit available in. If you want to get in the PACE program, for example, again, you have a different kind of assessment. If you want to, you can pay privately, but people can't afford it. So if you're on Medicare and Medi-Cal, they will pay for it. But again, you have a separate kind of assessment and you have a different income level in terms of spousal impoverishment will pay for that. So every single one of these programs is completely different in terms of, clearly you have to be poor, number one, you have to be Medi-Cal eligible, but each one has a different assessment, each one has different eligibility requirements, each one has, and the problem is for most of the programs, you have to be eligible for nursing home levels of care.
Okay, Michael, I don't see any other hands raised in the rectangle that has room for those, or I don't see anybody raising their hand in the array of micro faces here. So you can ask another one, or you can allow me to ask questions.
Betty Trainer asks, how can we come together to start writing legislation for improvements in long-term care statewide and locally? Who are the best legislators to work with?
We've been working with some. I mean, Hannah Beth Jackson, unfortunately, this is her last year and she's termed out. We've been working with Nazarian. He's been very interested in trying to do something. We've had different bills. We have a bill before the governor right now, which is 1207. Now that was a Hannah Beth Jackson bill. What that bill would do, it would require, it would protect from fires, require nursing homes to require 96 hours of power, of generating power, so that people don't die of heat, or that they don't, like they did in Florida in some of the nursing homes there. This is federal standards. I've had a hell of a time even getting that through, and whether the governor will sign it, I don't know. There's a lot of pressure from the nursing home industry. So just getting the bill through is one thing. Getting this governor, who's received a hell of a lot of money from the nursing home industry, getting him to sign a bill will be most interesting. So we don't know yet, because we know during the election there's going to be some other folks coming in, and we're looking to find, the Art Agnoses out there, or the Leo McCarthys, or the Sheila Kuehls, and I'm not sure that we have too many. Jody, and what's your experience with them? Anybody? No?
Okay, Michael, you have another question?
Why don't you go with yours, Art?
Okay. The question I put to Michael was, what can we do about the lack of legislators who are not tied to the for-profit healthcare industries? Do we need to start encouraging people that we know with values that resemble ours to run for office? You know, what can we do to get better legislators in office? Is that too going far afield of you know, what we can talk about here today? It's one idea.
I think that's important. I mean, you know, we've had a history in San Francisco of having legislators who actually cared about the aged and persons with disabilities. We've had a history of that. And I'm not saying that Scott Wiener and Chu don't care. I mean, I'm sure they do, but they've got their issues, and this isn't that. It isn't these issues. So, you know, they certainly care about other things, and they care passionately. But we're going to be testing a lot of them next year, and I don't know. We are writing a whole package of legislation. We're calling it the Long-Term Care Reform Act of 2021. And we will calling on you to see for your input, to see if you're interested in helping support something like that. But we have a 10-point plan. It's about long-term care. It's not just about nursing homes, because we have got to direct our resources in this state. And I think we all, Marilyn and Jody, we all are on the same road there. We all agree we have to start redirecting our resources towards other alternatives to institutionalized care. There's no question about that. But if we're going to have institutionalized care, and I think we need it, because people need rehab, people need, you know, certain kind, but we certainly don't need the kind of institutionalized care that we are providing in California at great cost, multi-billions of dollars that we are paying for the lousiest possible, even mediocre care that you could ever get.
I see Betsy has her hand raised, but if before she does, does the panel of speakers have any more comments on that last question? Okay, Marilyn, go ahead.
Well, I just think that we have to expose more the things that we've been discussing in this meeting about how the nursing home industry is so powerful in this state, for example, with democratic. We have to expose all of this more, and we have to expose what really is happening in these institutions and expose, unfortunately, there's a prejudice against old people, so that there's a tendency for people not to care, and this issue goes to the bottom of the list. But I think a first step is making more public, as the COVID epidemic has done, making more public what the real truth is about the profiteering that goes on in this sector.
Jody, you're unmuted. Jody, go ahead. You're unmuted. No, I'll unmute you now. For some reason, it's not letting me unmute you. Let's see. Let me try. I should be able to do that.
She's been having problems.
I'm gonna unmute everybody if I can. Oh, everybody's unmuted. So go ahead. You should be unmuted now. Okay, she can't talk. That's weird. Hopefully we can figure that out.
All right, this is Clint from over in Austin.
Plug in a headset.
Who's that?
Plug in
Who's
your
speaking?
telephone headset.
I'm sorry, there were two people talking.
Plug in your telephone headset. That will sometimes fix the problem.
I don't have one here.
No, for the person who you can't hear.
Okay, so Jody could try that. Okay, I heard somebody, was that you? Clint, was that you?
It's Clint in Austin.
Okay, go ahead, Clint, you have the question. I'm sorry, Betsy, let Clint go ahead.
Well, very quickly, this is a follow-up to Michael's question. First, I want to thank you and the leadership and all the information that you all in California, the Gray Panthers, have been supplying here to Central Texas. I'm speaking on behalf not only of the Gray Panthers of Texas, but also the Family Elder Care Board here, which is very much involved in senior housing as well as nursing homes, and also the Texas Senior Advocacy Coalition. So we're very much interested in following up on the information that's coming out of this, and I'm sure I'll have a tape that we can provide. Congressman Doggett, who is on he's chairman of the Health Subcommittee of the Ways and Means Committee in the House. And the elder hearing in June, 3 hours, and developed an awful lot of information. And so this will be very helpful as follow-up. We're working directly with his staff on these matters. He survived an awful lot of changes, and we're glad that we have been able to help him. He also is a former judge, and he is very much into evaluation and accountability. So I don't have a question. I just wanted to make the point, though, that I'll be following up with you directly because we can make good use of this information. And finally, particularly with the Texas legislature coming back into town, God forbid, at the end of this year, they only meet every 2 years, but the Senior Advocacy Coalition is very interested in pursuing the issue of accountability. And we have good information finally from Ombudsman as well. So wanted to thank you and make the point that we will be following up and making use of this information at the congressional level.
That's great.
Thank you. I'd like to unmute Betsy if I can. If not, she can just put her question in the chat and we'll ask it for her.
Actually, my questions have already been in the chat, and there were a couple of other.
Well,
I can answer the voting question. We just heard from the Department of Public Health and the Department of Social Services because we too were and we just put out our newsletter with a whole section on voting and what the election code says regarding voting in nursing homes and residential care facilities and for elders and persons with disabilities. And they sent out, the Department of Public Health has sent us a draft of their all facilities letter. And we corrected a couple of things because I want to make it very clear. The long-term care ombudsman can enter, and so can patients' representatives, to help them with their ballot, pick up their ballot, take it to the polling place or wherever you drop it off. With the Department of Social Services community care licensing, they're going to be putting out a PIN, a provider information notice about voting. And the ombudsman are going to be involved as well. We had a conference call recently, I don't even know what today is, but I think it was Friday, about that. So that's a big deal. And I wasn't pleased at all with the initial information they put out. It just said nursing homes are supposed to do this and that. It didn't say your rights are this, and you have the right to have a representative come in and pick up your ballot and take it to the polling place.
Mm.
Okay, Betsy, do you have a question?
Yeah, my question was from a while back, but it's this. We see that we have a whole industry of profit making off of essential public services. And I'm just wondering if basically if a lawsuit on the basis of similar to the equal voting rights wouldn't be in order. I'm actually thinking about the fact that the majority of people dying in these nursing homes are in fact Black and brown folks relying on Medicaid, I'm assuming. And if there is some seize the moment lawsuit, but that could be done to intervene. And I'm also aware that unless we actually change the entire organizational model of hospitals and nursing homes and senior housing, we can't really get out from under the grip of, wily predatory capitalists. So my question was about whether there's a lawsuit there, specifically around the racial evidence.
It's been
Who's
discussed.
dying.
I can tell you that because in the Gateway facility over in Hayward, a number of people of color were in that facility, and they had one of the highest outbreaks in California. John Burris's office was involved, and he was representing a couple. I think Adante Pointer has left John Burris's office, but he's still pursuing a number of the lawsuits there where people of color died.
Class action suit. I'm sorry, I'm thinking of a national class action suit.
Oh,
I don't even know
okay.
if that's possible anymore, but essentially a disruption of business as usual except we need these places operating till we have replacements. But it's just so egregious. So thanks.
Yeah, we're trying to fight. In the beginning, in April, we were fighting immunity. The nursing home industry, the healthcare industry, the hospital association wrote a letter to the governor asking him to put out an emergency order providing immunity to all healthcare providers from lawsuits, et cetera, et cetera.
Yeah.
We held a press conference immediately. It's ironic because one of his aides called us to warn us that so they got this letter. We held a press conference immediately. We got a lot of folks involved, the disability community, the advocacy community, ombudsman, et cetera. And he hasn't put anything out yet. And I don't think he will. He wanted the legislature to do it, and they, of course, didn't want to touch it with a 10-foot pole. But now Mitch McConnell is wanting to do that with this. That's one of the big fights in the Congress about he wants to dip that into the next relief bill.
Michael, do we have any more questions from the chat that you want to present?
Helen Walsh is trying to wants to add. She's muted.
I see she wrote it in the chat, right? Or was that a comment? Her comment.
Her comment was, yeah.
But is it okay for me to talk?
Sure.
Yes.
Okay.
Hi.
It was nice, Pat, that you talked about the communications thing. You noted about people not being communicated their rights and the communications aspect of this. So I'm wondering if we are going to continue looking at some of the areas of where, because everything is data-based. And what I'm noticing is data collected on persons with disabilities is not even included in surveys. Mm-hmm. And we also have the other issues of not full inclusion of seniors with particular mobility issues. It's not defined. Obviously, that's because of the ADA that there's different areas of that where they can't address it. But what I'm hearing from, and this is disability community areas, is everything is based on communications right now. And we're lacking in alternative ways for people who don't have access to digital content. When you call a call line, for instance, they've put in third-party people who answer phones. So even if you're trying to get information about what my rights are in a nursing home, and you try to ask your city information or figure out what path to go, the path is disconnected. So most people don't even know how to advocate because there is misinformation or non-information. And again, everything's based on data. So if the data isn't collected, which is because it's not connected in any kind of structure, then nobody ever gets to know. So you kind of have to go through piles and piles of stuff to actually figure out where this data is, because the structure itself doesn't include this data. And again, everything based on data, that would include nursing homes and our census and everything. And only the census this year somewhat included disability related questions. But when it comes to rights in a nursing home, the biggest issue there is people do not know their rights, are not told what their rights are. And if and all the ombudsmen are mostly volunteer, they're not paid or they are stipend. There's not enough ombudsmen. So what we have actually is usually you can trickle back up and fight. Well, what we have is this been going on for so long. They've strategized, sorry to sound pessimistic, but I have to, the communications here. The one thing technology is bringing to our notice is that everything is data collected now, and the public knows that now. But without the inclusion and without the educational component here, speaking in nursing home specific, people will not be able to be counted in areas of abuse, and they are not right now because there's not enough ombudsmen, so the data isn't collected, and two, don't even know they have a right to say they need help.
Well, that's one of the reasons why we do have a lot of outreach. We have video. We have all of our trainings and our town halls that we've held for consumers. We have all that on tape. We've got all of our fact sheets in English and Spanish and Chinese and some Vietnamese. I mean, we really try to go out of our way to provide people with information in various formats. Wouldn't have helped my mother, who was blind, but the tapes do. She listened to tapes all the time.
Well, but it is people. What I'm speaking about is exactly, I'm glad to hear there's different formats, but that's also one of the major issues. Many people can't attain that information unless they know who you are or who your
I know, I
organization
understand,
is.
yeah.
So that's what I'm saying. So at one point in the digital divide, I was contributing to the different proprietaries. Can't you all work together? Because the communications is one area which is going to weaken this fight. And I don't want it to. And
No,
that's the area I've been
agree.
looking at. That's my advocacy area in the disability community is
Mhm.
specific to communications. So that's where I'm coming from. Yet I do know what's going on in nursing homes, and I do agree, and I'm boots on the ground there too, but that's my specialty area. And I see it as a big concern unless we start working more cohesively together so people can locate the information, because you know they're going to ask you, we want the counts. And you can't get the data if people don't know you're there.
Mhm.
Okay, thank you. Pat or Marilyn, do you have a comment or an answer to what Helen was saying there? And I think Jody may or may not be, I think she was trying to overcome her audio problems by calling in, but I don't know, I don't see her phone icon. If you're here, put something in the chat, Jody, or let Michael know.
I'm on the phone. Can you hear
Okay.
me?
Yes,
Oh,
I can.
great.
Go ahead. Did you want to answer Helen's comment or question?
No, I didn't hear the whole question. I'm really sorry. I got thrown off Zoom for some reason, and so I'm on by phone now.
Okay. Do either of the other two panelists want to answer Helen's concern or question?
I don't have enough expertise to
Okay.
deal with this particular question.
I'm not sure what the question is.
Helen, do you have a question? Can you put what you're saying into a question?
Yeah, I could try. I mean, I guess I understand within organizations that you have communications and outreach, but how is it getting beyond just that organization? Because the community areas count. So how are you working in conjunction with other organizations to ensure that, sort of like you had said there, Pat, you know, providing something that was more specific that you pointed out, that this information has to have about what your rights are, what to do, instead of generalizing it.
Well,
Because I know those, you know,
we work with every legal services organization in California. We're a legal services support group. We're funded by the state bar partially to provide training, outreach, advocacy support to all the legal services programs. We also do free training for legal services and for the long-term care ombudsman. We provide thousands of books and fact sheets to these organizations to provide to consumers. But I honestly don't know what else. I mean, obviously we could always do more, but I don't know what else. I mean, we're always willing to take suggestions, but you know, not everybody's going to know who we are. We've been around for a long time. We've done outreach for a long time. We do, you know, community events. We do, you know, town halls. We had 400 and something people at one of our town halls, and you think this is bad. It was very, very difficult to keep up with all those people. It was on Zoom. So any ideas that you have, any suggestions, we'd appreciate it.
Yeah, and I will think about that and look into that, because I know that's one of the responses that I normally get. It's just sort of, how do we integrate this a little bit more is sort of what I'm now starting to look at. And
okay, Helen.
I'll look for ways to help, basically.
Hey, are there other questions? I'm not trying to end the meeting. I do have things I would like to say or ask, And we have about 10 minutes left. Is there anybody else who has a question or comment for any of our speakers? And Jody, did you want to jump in on anything because you were away?
Well, I lost some of the questions because I was trying another way to get in. So I'm here now,
Okay.
but I missed some of the previous questions.
Does anybody have a question for Jody at this point? How about a final set of comments on what you think let's say recommendations for us, what can we do as activists to make some things happen, some of the things you may have been talking about today. And, you know, Sylvia, did you have a question? I see you waving your hand.
I type it in the chat.
Okay.
My comment is, since we are talking about focusing on the profit, so why don't we cap the profit margin to no more than 2% of the operating costs, okay? If their revenue from the premium is 50 billion, like Kaiser, their operating costs could be 55 or 60 billion. So it just has to be no more than 2% of the operating costs. And you know that they have very clever accountant and tax preparer to evade the tax, keep the cash, and grow the assets by writing off on donations, just to improve their image, public image, and just to mention a few. But don't let them give us the excuse on the healthcare worker pensions, taking the bite, or the lawsuits. Healthcare worker pension can come from or drawn from the outside of healthcare investments. Hospital always have, like they use the Fidelity, or they use the Charles Schwab or the RAID or equity, private equity firm, startups. So those generate, is already big enough. And they keep on building more hospital to monopolize it. And pretty soon we will be like the bank that all the commercial tiny community bank will disappear and you only end up with 4 banks, okay? That's something like that is heading to that. So why, if we're focusing on profit, why don't we talk about the profit? That's all.
Okay, Pat, Marilyn or Jody, you have a comment?
Well, I brought that up one time at a hearing in the assembly, and a couple of the more right-wing Republicans said, "What are you, a communist?" So that,
You know what? When we get down to the bone, they don't like it.
No, and I also think that we tried to get cost of living increase caps for what they can charge and how much they could raise the rates for nursing homes. They can charge whatever the market can bear. Same with assisted living. They can charge whatever the market can bear, as long as they give 60 days notice. But we've seen people during this COVID crisis have their assisted living rates go up $500, $600. They tell people you can only have meals in your room, and then they charge them an extra $500 a month. So yeah, we need caps on all of this stuff, on profits, on the charges to residents, etc. I mean, it's a very good idea.
Marilyn, what do you say?
I just think that all of these issues that we've been talking about everything is interconnected to many other social justice issues. And we're beginning, like we learned during the pandemic, we saw the interconnection between the pandemic and the realization of the terrible racial disparities of COVID-19 and the interconnection between the Black Lives Matter movement. And we probably wouldn't have anticipated that. But so I think that more and more we're seeing what is wrong with this country and the gross economic inequalities that exist, that the issues are so interconnected with each other and that we should try to really cross the generational lines around these issues, which is hard to do, but to connect it to universal health care, to connect it to racism, to connect it to women's equality. And all of these things really are coming together much more than they used to. And so that hopefully will help us build a stronger, broader movement for the phrase that kept coming up during the election, big structural change. I think that's what we should all be trying to unify around.
Jody, what do you say?
I would agree with what Marilyn just said. I think that, healthcare is a human right, and we should be working from every aspect of the healthcare industrial complex, whether it be in nursing homes, assisted living, hospitals, healthcare, to make sure that everyone has access to a standard benefit that includes all body parts and all ages across our lifespan to address, so that we're not dealing with, is this nonprofit or for-profit? Do we need to regulate their rates? If we had, global budgeting for the facilities that provide care, whether it's acute care or nursing home care or boarding care, and
Oh, shoot. Sorry.
Ooh. She's in the 415 area code.
I think I.
Did you just hear me again? Can you hear
go
me?
ahead.
Yes.
Sorry, I interrupted you. Go ahead.
I just feel like we need transparency and accountability. And if we had a global budgeting system that negotiated for rates that were fair, that treated workers fairly, regardless of the facility that you received your care in, hospitals, inpatient, outpatient, nursing homes, we would have a much more public process that valued that the care that we get and the workers who provide the care, that supported the family caregivers in our system. And so it is a huge systemic problem. And, we're trying to, today we're talking about the nursing home industry and how it discriminates, how it overcharges, how it's unaccountable. But it's true across our healthcare spectrum. And so this is, as Marilyn said, and I think Pat said it too, it's part of a much more global system. And we need to reform the entire healthcare industry and make healthcare a right. And pay the people who provide the care what they deserve, make sure that people have access to care, whether they live in a small rural community or a large urban area, regardless of race, regardless of age, regardless of ability. We need to get there. And this is part of that cry. And I think we're in a moment right now where COVID has brought us together in a way that I don't think would have happened without this pandemic. We are each other's keeper. Our wearing a mask impacts the person across the street. So we need to take the energy and sort of the cry right now for Black Lives Matter and for healthcare justice and merge our efforts in a much more organized, strategic way than we've done before. And I think the opportunity is here now, and we should take advantage of it.
That was a beautiful set of closing statements. We had Teresa Palmer with a question. I think she may have just left, but we're close to the end. So I just want to say a couple quick things, that the Gray Panthers locally and nationally are working on this issue. We have a resolution that Michael and I worked on and approved, and also Betsy worked on it here. And it's available as a tool with a script and that you can use when you talk to your legislators. As Clint said from Texas, he's working with Lloyd Doggett, member of Congress, to develop legislation, as is Jan Bandor up in Michigan. And I've also been following Scott Wiener. He was on a Senate committee that they had a special hearing on the nursing home crisis during COVID, those overlapping crises, and they seemed to come to some. They examined it, but I wanted to follow up.
I testified at that hearing.
Yeah, several of us testified. Well, I commented. Thank you for your testimony there. So I wanted to follow up with them. I got a call from one of his assistants, one of his aides, and when I shared that with Charlene Harrington, who's a UCSF expert on nursing homes, she said, we should be talking to Canner and working on your legislative agenda, because the department that's in charge of this is not really, they make broad statements about what the nursing home should be doing, but with some specificity, but they're not really doing it. It's like greenwashing in the environmental sense. What would you call it in this sense? It's,
Gray washing.
gray washing. So I'm calling for a gray New Deal and to defund the nursing home industry.
Whitewash, yes, gray wash.
So I want to thank our speakers. Thank our speakers and our participants for coming, and everybody. I think it was a good forum. We do have a recording that we should be able to share. We do these forums every month. And next month, I think our topic will be fascism and what to do about it. And so stay tuned until they haul us away. We have one more thing to say about fascism before we get locked up.
Well,
okay,
remember the useless eaters was the term that fascism used for elders and people with disabilities.
Useless.
Hey, semi-useful, not fully.
We have some information. Thank you. We have some information in the chat. I think the speakers put some of their information in the chat. Is that correct? About what we can do about Prop 15 and how to get a hold of Canner. And if Marilyn has something she wants to post in the chat, she can do so. I'll hold it open.
I just put the website for Healthy California Now, which is our group that is fighting for a state California single payer system. The website I put in the chat.
And there is a forum tomorrow night with Bernie Sanders, I think Jayapal too, if I'm not mistaken.
Yeah, there is.
So contact me if you want more information about that. So thank everybody. And if you want to get the chat, you go to the bottom of that rectangle, and you can see 3 dots next to each other, and you click on that, and that you can save the chat for you, and it'll show up in a file on your computer, or you can contact me and I can send it to you because I'll copy it. Okay,
mine doesn't allow me to save chat. I use VoiceOver, so I'm not hearing it.
You can contact me. I'll save the chat and send it to you.
Okay, great, thanks.
Okay, thanks everybody.
Thank you.
Thanks.
Thank you.
Thank you.
Thank you, Jody, Marilyn.
Thank you so much.
Bye.
Thank you.
Thank you from Miami.
Bye. Great jamming. Hi, Ramona.
Hi, Betsy. How are you?
I'm good. I've gotten 2 notices from San Francisco, and tomorrow at 1:30 is our East Bay meeting. So it's quite, I wanted to invite people, but it's more close to home. But you're welcome. We're having some speakers talk about living with disability, basically older adults, and Helen, so that we can even strengthen our coalition with disability activist groups.
Oh, that sounds great.
Really get to know our neighbors better. And they're Gray
Sounds
Panthers and there's Gray Panthers and affiliates and people who've come and other people who've never been. It's like 3 speakers, maybe 4. Anyway, and then we have our ballot propositions. So I'll let you go.
Thanks for being
good to see you.
Thank you. Hope to hear more from all of us. Bye-bye.
Thanks so much. That was great.
Thanks for being here.
Great job, Art.
Oh, thank you.
Great job.
Good job.
I prove every time how human I am by not being perfect. So there you go.
Okay, bye.
Bye, thank you. Gail, Gwen, Denise, are you still here? I think you're muted. Okay, I think you should be unmuted now. If Gail, Gwen, and Denise, are you still here? I think you're gone. I think you've abandoned your post. So I'm going to end this. And thank you for coming, and talk to you later.